Hello and welcome. I'm Garrett Hollembeak, and you're watching Abstraction Notes. We're here today with Scott Mader, President and CEO of AseptiScope, to talk about a risk and maybe a hidden risk to our patients in a clinical setting, namely contamination of stethoscopes. So, Scott, welcome. We're excited to have you on today.
It's nice to be here, Garrett. Thanks so much for the invitation.
Absolutely. And so we're going to be referencing throughout a great piece of research that was done, and I'll read the title off here so I don't mess it up, but it's Molecular Analysis of Bacterial Contamination on Stethoscopes in an Intensive Care Unit. And this piece of research highlights something that I think we know in the back of our mind is maybe a risk. I know when I see clinicians or physicians, seem to be some of the bigger offenders walk in and out of rooms with their stethoscope, and sometimes maybe the patient's in isolation, or maybe the stethoscope doesn't get cleaned as well as it should. So all of those things are concerns for the infection prevention world. And Scott, I think you're seeing this come to the forefront of patient safety concern.
We are indeed.
So getting into this research article, Scott, can you tell me a little bit about how big of a problem is this? How big of a problem is bacterial contamination of stethoscopes?
Well, it's becoming more and more of a high awareness issue. When you and I first corresponded, you did take note of the disparity between what the Connect study folks say and the concept of non-critical items. This is a non-critical term as somebody who comes in from industry, and what my group does is identify clinical challenges and fill it with innovation. It was very remarkable to me when I saw data going as far back as the 1960s, but really starting to accrue in the last decade or so, to see this term, which of course has a specific meaning, and that's why it was characterized that way. But we've been very happy to see that the CDC is altering the way it frames that in its new 2024 guidelines. So we are seeing that Connect brought very unique data to the table, a very unique bolus of information, but it's very consistent with what we continue to see out there, which is that this is every bit as contaminated as the hands, but we're not really doing anything about it.
That's right. I think most of us are familiar with all of the effort and energy that goes into hand hygiene, personal protective equipment. Stethoscopes are almost kind of a blind spot. Now, for our audience that maybe is not as familiar, can you lay out what non-critical means, or what we mean when we say that?
Well, the thing is non-critical in my understanding as a non-infectious disease professional or infection control professional, it really means that the criticality of this item is such that it doesn't need to be validated as a sterilized product that is, if not, is likely to have a significant infection control challenge. And this is in the open clinical environment. The interpretation, however, when you're talking to the average nurse professional, there's an implication to non-critical that is inferred. And that is that if somebody tells you should be cleaning something, but it's not critical, it really undermines the entire problem.
Yep. I think you hit on a good terminology thing there too, that if it's non-critical in our head, does that mean it's not important to clean or pay
Right.
attention? I think sometimes we do.
Yeah, that's just a natural thing. When something is non-critical, it means, what cleaning it is not that critical, and it's not it's not the way it's intended. It's oftentimes the way it's digested.
Mm-hmm. Now, from this Connect study, can you give us a little bit of insight into some of the types of contamination they saw, and also the severity of the organisms that they saw?
Yeah, this was a great, when it came out, it actually became public in December of 2018, and it created a pretty good stir because it looked in a more comprehensive way. A lot of the data had been out there about stethoscope contamination, particularly on the diaphragm, and Connect focused on this. But what they showed with molecular testing was the full range of contaminants that are on stethoscope diaphragms, and they looked in a an ICU setting, which is a perfect place to do it because the toughest bugs are out there and the most fragile patients are out there, meaning stethoscopes are constantly touching them. Oftentimes every hour they're being auscultated. So what they did in this molecular testing was to look at both types of stethoscopes out there: personal stethoscopes, professional grade stethoscopes that are worn around the neck to and from patients, and also those that are used in isolation settings that are called single patient stethoscopes, or sometimes disposable stethoscopes. And what they found is that both of them are highly contaminated relative to controls or clean stethoscopes.
Now, in your experience with this type of issue, is there a reason that we're seeing equal contamination or close to equal contamination between the personal stethoscope and the cleaner or supposedly cleaner disposable ones?
Well, we've done a lot of this work ourselves because we're in this business. So in preparing for developing a solution or an innovation for this, we really looked hard at it. Professional grade stethoscopes, they move they are dedicated to the clinician that's using them versus single patient stethoscopes that are dedicated to the patient who is being assessed. That's the essential difference. With a personal stethoscope, you're in control of your own stethoscope.
Right.
And that means your cleaning habits really are going to be reflective of what's on that diaphragm. However, when you have a dedicated stethoscope dedicated to the patient, everybody on staff is touching it. Everybody on staff is using it. And now the habits of everybody are associated with the hygiene on that stethoscope.
That's a great call out because it almost creates a double risk of contamination, one from the patient side and then one from the care provider side.
It's true. It's absolutely true. And it's reflected in this data.
Mm-hmm. Now, I know we're used to seeing kind of the typical microbiome on our hands and just in a healthcare setting. In this study, did they find that there were more significant or more dangerous organisms outside of that typical microbiome?
They did. They found both pathogenic and non-pathogenic. They found them. I believe they call what is referred to as nosocomial or MDRO type of pathogens. So you certainly found MRSA and staph. You found Enterococcus, and you found Clostridium difficile. A lot of these things are some of the toughest bugs out there. These very resistant pathogens. And of course, you would expect to find them when the patients that are being auscultated in an intensive care setting, meaning that they are compromised significantly. And as we know, hospitals tend to be a haven for some of the toughest bugs.
You're absolutely right. I think that the concept of the patient in this setting is we're used to thinking of skin as an intact barrier and a pretty great barrier for infection. But if they're bleeding, sweating, diarrhea, there's all sorts of other compromised layers on top of that skin. So even if you may be listening to the chest, you may be picking up a number of organisms.
Yep.
Now, did this research go into the current practice for cleaning this type of device, these stethoscopes?
It did. As a matter of fact, it had two different methods of cleaning that they assessed. They assessed what was kind of a standardized cleaning method. And this is one that has been assessed in healthcare, but never actually has been documented to take place. And that's 60 seconds of cleaning between patients with hydrogen peroxide for literally the diaphragm itself for 60 seconds. The second one was the clinician's method, which is variable. And it introduces human factors into it. How much time you're taking, what are you using, how close are you doing, how close are you paying attention to what you're doing. So those two different cleaning methods were deployed, and they had different outcomes and similar outcomes.
Can you go a little bit more into that on what the differences were and what the similarities were?
Yeah, so the differences were that the standardized cleaning approach, which is difficult to deploy, requires 60 seconds of cleaning with hydrogen peroxide in a standard methodology. That reduced had a significant reduction in colonies, but only 50% of the stethoscopes cleaned that way were returned to what they call clean status.
Mhm.
The clinician's preferred method, only 10% were returned to clean status. The common link was that they both reduced but did not were not adequate in decontamination.
Wow. I think that's a shocking number to hear that the preferred method, 90% of the time, you're walking away with a contamination that you're
Yeah,
going to carry directly to another patient.
it's really it's startling.
Wow. Now, when you get into the preferred method, even if you're using a hydrogen peroxide wipe, then we have follow up on what's the wet time. Are we allowing this to, are we using the same method to clean it? Are we all being as detailed? And are we really counting 60 seconds? Uh, those are tough barriers to overcome using that type of method.
It's really true. And if you think about the clinician's priorities, it's very difficult to even consider the idea of 60 seconds of cleaning between patients. The
Yeah.
stethoscope is used ubiquitously and constantly. And so the idea of dedicating a minute to it, we actually did a return on investment analysis on this. And it's
Mm,
not practical, it's not workflow compatible. But the
yeah,
truth of the matter is, it costs you a lot too.
right. A minute of physician time that stacks up very, very quickly.
Yep, exactly.
Now, from more of a provider preference side, I know I've heard in my experience that there's some hesitation to use single patient stethoscopes. They may not be as comfortable, they may not be as accurate. Did you, or did this research, or in your experience, have you found that to be the case as well, that providers really do prefer what they've got around their own neck?
Yes, and we know that to be the case, and I've actually never talked to a clinician ever that didn't dislike the idea of single patient stethoscopes. When you graduate from nursing school or medical school or technology school, or if you're a respiratory therapist, you pick out your stethoscope, and it's a source of pride because it's something that you've trained to do,
Yeah.
and it becomes a part of the way you approach your patient. The other thing about it is they all know that not only the diaphragm is contaminated, but their earbuds have dramatic contamination. When you're sharing that among staff, it's an uncomfortable idea.
Yes, that's a great call out because if you are sitting next to your coworker and you say, "Hey, I'm listening to something. Do you want to put my earbud in your ear?"
It's
You're going to get
it's
a mixed response on that.
it's
Yeah.
not good to think about. And I'll tell you the other thing, Garrett, about them is we anticipated what most people said to be true, which is that I can't hear out of them. They're a lower quality stethoscope. They're dedicated to a single patient. They cost about $6. So we actually did a controlled study of this, published it in the Mayo Clinic proceedings, and you
Hmm.
lose about 11% of diagnostic accuracy. So this is a major problem.
That really is 11% is huge, especially when you're looking at very detailed, I mean, cardiology patients. That's a huge one.
These are exactly. So in fact, diastolic murmurs, for example, those are one of the ones that are commonly missed.
So, real functional risk to single patient stethoscopes, a real contamination risk to the cleaning practice of those. Where do you go? What do you do from that, knowing that there's limitations on both of those ends?
Yeah, there's not a lot of options. There are proposed options. If you only needed to use this once and then clean it overnight, it would be something that you could go through UV or sterilization processes, but you can't do it as quickly as the stethoscope moves from patient to patient. So we went about analyzing this through a method that we call market-driven science. It's when the
Mm,
market tells us what solution would work, and we
okay.
develop attributes that become the release specifications for an innovation technology. And
Mm,
we have developed our innovation, and we've validated it in a pretty extensive clinical library. It's available online, and we're now commercializing it. It basically is a fully effective glove
mm,
for the
mm.
clinician's third hand, which is what the term the clinician's third hand appeared in the literature about 2015 or so,
Uh-huh.
referring to the stethoscope. And so we've developed a clean glove for the clinician's third hand that gets applied in a totally touch-free manner and it's fully aseptic.
Very interesting. It reminds me of the push in recent years to go to touchless lure connections, touchless IV.
Yes,
And
that's
that's
exactly right.
been a great concept for infection prevention. So this is a similar adaptation where the contact is not coming from provider to patient to device.
You know, we were fortunate enough to just a few weeks ago be featured in the USA Today in a feature article,
Hmm.
probably because the CDC is really changing requirements for stethoscope hygiene, and
Mm-hmm.
so as a result, this innovation is getting some attention. But the president of the World Federation of Intensive Care Nurses, Kathleen Volman, was quoted in that piece as saying almost the exact same thing that you said about the IV innovation, and how this innovation essentially resolves the same thing for stethoscopes.
So this is essentially a cover, I'm assuming similar to a probe cover, a sheath that goes directly on the diaphragm.
It does, and it fits all diaphragms, and it fits it immediately, and it applies it in a touch-free manner. The thing about it is the market told us a lot of things, and so it's not quite that simple. It is
Mhm.
that, but it has to be workflow compatible. Everybody's got stethoscopes, so you can't have it has to be intuitive. You can't have a long training program for it.
True.
You have to demonstrate and prove that it is an effective barrier, not just to these pathogens we're talking about, but also to contaminated patient samples, whether it's sputum or urine or feces or blood, et cetera. And so we've developed a bulletproof one. It's acoustically invisible. We have
Okay.
validated it. And actually, at the end of the day, people really like using it. And here's what's coming: patients like it too. Garrett, in the post pandemic period, patients are very well aware, are highly aware and sensitive to infection control
Yeah,
and the worry about healthcare associated infections. And they see this applied immediately and they know exactly what it's for.
that's fascinating. I know, rounding on patients, the just as you said, the awareness and familiarity, literacy, and infection prevention practices. You'll go into a patient room, and if somebody misses hand hygiene, patient will tell you, or they'll
Yep.
say, the other nurses or staff were coming in wearing those gowns, and do you need one? Should you be wearing one?
Yes.
Which is great from a patient safety perspective. We need that. We need the patient. Patient should never be the first advocate, but they should be on that advocate list to keeping themselves safe.
Everybody's part of this. It's really a team effort. And I like the way they've recruited patients to consider hand hygiene. And
Yeah.
with stethoscope hygiene, there's not really an opportunity when you are trying to clean it. Nobody can see the bugs that are on it or not.
Right.
And with this, they see this applied, they know exactly what it's for, and they feel comfortable. That's by the way, a study that'll be published in June out of the Cleveland Clinic Foundation.
Very exciting. We may have to do a follow up with you interview on that. Now,
Be
you
happy to
used a
do
term that I'm not familiar with, but you said acoustically invisible. What does that mean?
it. It's a great, I'll tell you what, it was new to me when the investigators used that term in the publication.
Hmm.
We did develop this material and selected it based on not only its ability to be an effective barrier for pathogens, but we did look to make sure that it transmitted sound clearly. And the way that it's applied to the stethoscope essentially should be like a single use diaphragm. And so we developed it that way. But the investigators were not only able, we knew that the sound traveled through it, but
Hmm.
the investigators that published the Mayo Clinic, they found out that they diagnosed with the same agreement, 100% accuracy
Wow.
to the control stethoscopes.
Wow. So not only are you getting rid of the contamination risk, you're not having that 11% reduction in the specificity of the instrument.
Exactly right. And it was in that same study that 11% misdiagnosis rate with the single patient stethoscopes
Hmm.
was identified.
Very neat. Now, I know as an infection preventionist, I'm always concerned about how not only people are donning PPE, but how they're doffing it. So if you're using a
Mhm.
single use stethoscope or diaphragm cover, how is that doffed? If we're treating that
Yes.
like a piece of PPE.
So it's there's nothing better than a visual, and I know we're having this conversation, but online you can actually see this very clearly. We have actually a finger tab that's non-adhesive. It's at the
Hmm.
base of the disc cover, much as you would remove a glove. It is not. It's the non-adhesive component. It's polyolefin, and you then place it in the same place you're placing your gloves and other PPE within the room before you go on to the next room, when you are, of course, reinitiating hand hygiene in a new stethoscope cover. This, by the way, this system, it actually does fit right into hand hygiene stations. So it's designed to go exactly where hand hygiene is located.
That's a key thing, because you don't want to reinvent the wheel. If you can
No.
integrate a new best practice into an existing best practice, that's always what we strive for.
Yes, exactly. And we're looking to leverage those learnings.
Yeah. Now with the single-use stethoscope covers, is there any tape, any residue, anything that critters can stick to once it's removed?
No, it's a terrific thing about this. So there is a tack. Now this is a 3M technology, and
Hmm.
if you're familiar with the Post-it note concept,
Yeah.
this is something that the patient-facing side has no residue on it whatsoever. It is
Hmm.
biocompatible, of course, as required, and the stethoscope side that you apply it to the stethoscope with is has not seen the light of day
Mm.
until you actually request it, and it goes into the application window and you apply it. So this technology is actually totally aseptic, developed in clean room conditions and
Wow.
sealed and shipped from clean room conditions until the moment it's applied to the stethoscope. So this is a
Very,
very unique feature.
that really is, and it solves that problem of how am I going to apply this without, contaminating or recontaminating something?
This
How?
is, from your world, one of the things that we were seeking to do
Mhm.
is to automate aseptic technique, where we're actually allowing within a single second the ability to have a totally aseptic technology that has been maintained aseptically and protected in our clean cassettes until the
Mhm.
very moment it's required, and then it's delivered in a touch-free way. And so this was kind of, we followed that roadmap that you people practice with routine, but we've tried to make it in a way that is a single second to apply.
Wow, very impressive. Now, how widely, because I know we see the single patient stethoscopes very widely used, how widely adopted are single stethoscope diaphragm covers?
Well, we just launched at the back end of last year. In the third quarter, we received our manufacturing license, and we
Mhm.
immediately began selling this technology in the United States. We are registered with the Food and Drug Administration and cleared, and we are now selling. So you'll find us in places like the Cleveland Clinic's ICU. You'll find us in cancer clinics. You'll find us in VA hospitals. We are now listed on the Health Trust's Innovation Center, a big GPO, Viziance, in the Department of Veterans Affairs. So we can access about over 80% of U.S. healthcare now comfortably. And
Wow.
so we are now turning from, having a product and a technology that is validated and people like to use, to scaling up. And so we are moving pretty fast into the market space. But the CDC's new guidelines are going to really make it a big deal. So we are right now really developing a fully robust scaling for manufacturing, because they'll essentially be requiring that the Joint Commission make sure that stethoscope hygienes are in place. And the study that you brought to the table here, the Connect study, it has the same conclusions, but those conclusions were back in 2019. So the CDC is now caught up with it, and we're going to start moving pretty quick.
I think that's exciting. You see that trend where the body of research almost precedes the, technology catching up to it. And so it's exciting to see this coming together.
We're very excited about it. And I got to tell you, I didn't realize, I've worked in a lot of different areas of healthcare, but
Hmm.
in infection control, you guys it's a very, very all consuming area. And you've got to do it in a way that's actually feasible, in a high workflow environment where life and death decisions are made. And you have to keep these patients safe. So we're really happy to be bringing innovation here. And one of the things that I know also drives hospital considerations is things like sustainability. So this was developed with less than 0.5% of the material waste that you see with these disposable stethoscopes. So it's really we've really thought a lot about this and about the challenges that you guys are dealing with.
That's very exciting. I know we live in a world where PPE is put on and thrown off, and we go through just buckets of it. So to hear about a sustainable solution is exciting.
Yeah, I would love to be able to come back and chat with you about it. I know your audience probably has heard a lot from us today, but we're excited that you've had us on, and I would love to chat with you about a lot that's going on, not only with the Discover system, but with this kind of technology and how we're bringing it out.
I think you hit the nail on the head. This is not just a new product; it's a new mentality, new culture shift
It
in
is indeed.
this world of non-critical and low-level disinfection.
We're excited to be a part of it with you, and I'm just couldn't be happier that you invited us to be here today, Garrett.
Well, Scott, we appreciate it, and we'll talk to you soon. Thank you.
Thank you so much for your time.